Hello, this is Chris Bush from Maryville University. Today I'll be doing my head-to-toe physical assessment on my patient Ben here. So far, Ben has emptied his bladder. We've also done his height, weight, vital signs. All were in normal limits. Also tested his vision on the Snellen vision chart. His vision is 20/20, no deficits. Patient doesn't wear contacts or glasses. And now we'll begin with our physical assessment. First, I want to test some cranial nerves. So Ben, if you could smile for me and frown. If you can close your eyes really tightly, you can clench your teeth and puff out your cheeks. Perfect. And now I'm also going to start with the scalp region. I want to feel the scalp for normal movement. Also feel the hair for texture. Scalp has good movement. Hair is not coarse or brittle. Next, I want to move to the facial bones. I want to feel his facial region. I'll feel the frontal, maxillary, ethmoid, also his chin region. Let me know if you feel any tenderness. Any pain present?
No.
Okay. Next, I want to do a light test on the similar regions, basically assessing for any fluid, any inflammation that may be present. All of that looks normal. So now we'll move down to the eyes. And similar to what we first did, I want to inspect first. So I want to inspect his eyes. I'm going to look at his eyelids, eyelashes, his eyebrows, checking for symmetry, making sure there's no masses, any lesions present. Next, I want to look at his sclera, make sure no jaundice is present. Also want to look at his conjunctiva, make sure they're white, no nodules present. Thank you. I'm also going to palpate his lacrimal apparatus. Next, I want to do some vision testing with Ben. We're going to start with the cover-uncover test. Ben, if you can cover your right eye. Now remove it. Good. One more time. Good deal. Same with the left. One more time. Fantastic. Basically looking for any kind of extraocular movements, any strabismus that may be present in the eye once he uncovers it. Now I want to do the confrontation test. I'm going to have Ben stare into my gaze. I'm going to return his gaze and then assess his vision in lateral fields. Just let me know when you see my hand come into...
I see it. No. No. No.
Thank you. And also want to check his extraocular or his cardinal fields of vision. So if you follow my finger. Very good. Next I want to test his pupillary response, looking for a direct and consensual response. Direct response will be the eye that I'm shining the light into, looking for consensual constriction on the opposite eye. After that I'll test for a red reflex in his eyes as well. So we have direct and consensual constriction. Next, I'm going to dim the lights, look for his red reflex. Going to change my lens for this. Through the ophthalmoscope, we have red reflex present in both eyes. For the next step, I want to check Ben's ears. So first, we're going to inspect, as we did before. Tell me if you feel any discomfort.
No.
No discomfort present in the auricles. Next, we want to do some hearing testing with Ben. We'll start with the whisper test, then we'll move to the Rhine and Weber test. And for the whisper, I'm going to have Ben occlude one ear. I'm going to whisper a word into the other ear, have him repeat it, and then switch with the other ear with a different word. You can include one ear for me.
Cat.
Now the other ear.
Dog.
Very good. Next, with the tuning fork, we're going to assess the Weber first. I'll put the tuning fork midline on Ben's head, have him tell me if he hears the sound better in one ear or the other, or if he hears the sounds equally. Then we'll do the Rhine test after that. Put the base of my tuning fork on Ben's mastoid bone. He'll tell me when he can no longer hear the noise. Then I'll move the tuning fork to his ears and have him tell me when he can no longer hear it then. Normally, air conduction for the Rhine test is twice as long as bone conduction. Can you hear this equally in both ears?
Yes.
Yeah. Next, we'll do the Rhine. Just tell me when you no longer hear this noise. Say now, and you can.
Now. Now.
Perfect. Repeat with the other ear.
Now. Now.
Perfect. Now that we've done those, we'll move from the ears to his nose, then from the nose to the mouth and pharynx. For the nose, I want to inspect the nose first, look for any visible masses that may be present. Nose looks fine. Next, we're going to go internal to his nose after we palpate. And I basically want to see if his septum's midline, if his turbinates are enlarged at all. If you could tilt your head back a little bit, and kind of occlude. Perfect. And we also want to test the patency of his nose. If you can occlude one there, breathe in, occlude the other. Perfect. Now that we've done the nose, we're going to look at Ben's mouth. First, I'm going to look at his lips, buccal mucosa, have him open his mouth, look at his tongue, look at his tonsils, make sure there's no inflammation, enlargement. We'll also look for the uvula to rise midline, and if he can stick his tongue out, make sure his hypoglossal nerve is intact. You can open up for me. Perfect. You can stick your tongue out, side to side. Perfect. One more time to the left, not to the right. If you can lift it up, okay. Say ah.
Ah.
One more time.
Ah.
Gag reflex. Gag reflex is present. Sorry about that. So we also want to look on the sides and under the tongue. Those are the most common sites for oral cancers. Make sure those aren't present. Next, we're going to move from the mouth. I want to go down to the neck region. And before I start, I want to look at Ben's neck. I'm going to inspect it. Make sure that the trachea is midline. Also going to feel for the thyroid. Make sure you don't feel anything or any enlargement. Could indicate hyperthyroidism, thyroiditis. Neck here. And for tracheal position, I'm going to stand behind Ben. I'm going to have him swallow while I palpate the trachea. If you can swallow a couple times for me. Done. Perfect. Now that we've done this, I also want to assess his range of motion. We'll do some passive and active range of motion exercises, testing the strength of the cervical spine as well. You can touch your chin to your chest, all the way back. Turn it to the left, to the right. And if you can touch your shoulder with each ear. Do you feel any pain with that?
No.
Okay. And if you can try against the resistance in my hand. Turn. Turn. You can go back. Now front. Perfect. Next, with the neck region, I want to assess his lymph node areas. Make sure we don't feel any lymph nodes present. Normally you can't feel any lymph nodes. One of the last areas I'll check is the supraclavicular, one of the most common areas for malignancy, if any is present. First, I'm going to do the preauricular, postauricular, then occipital. Then I'll move to the tonsillar, submandibular, submental, the anterior cervical chain, posterior cervical chain, supraclavicular, infraclavicular, and then axillary. Do preauricular first, postauricular, occipital, tonsillar, submandible, submental, anterior cervical, posterior cervical. And if you can kind of hunch yourself forward and give yourself a hug, this helps you better assess the supraclavicular. You can lean back for me. This way we'll do the infraclavicular. And then I'll have the patient raise their arms above their head to do the axillary. You can raise your arms up like this. Very good. So now we've assessed our lymph nodes, we've looked at the neck, looked at the trachea, we've looked at the thyroid. I also want to test his carotid pulses. I'm going to feel for those, feel for bilateral symmetry. I'm also going to listen to him with the bell of my stethoscope and assess for any bruits. And while I'm feeling, palpating, I'll feel for any thrills that could be present. Alright. We've got good upstroke on the carotid pulses, 3+ bilaterally. Now I'll listen with the bell of the stethoscope. No bruits were heard on the carotid arteries. And now that we've done the neck, I like to move next to the upper extremities. Basically, since Ben's wearing a short sleeve shirt, we've got better access to the arms. I'll look at the skin, see if any masses, any irregularities are present. I also look for hair distribution, make sure he has good hair coverage, hands, and the wrist area, similar to the lower extremities. If there's any deficit there, it could indicate PVD, PAD. Next, I want to look at Ben's fingers. I'll assess for his capillary refill. Which is less than 3 seconds on both hands. Also, I want to check for any clubbing that might be present. So Ben, if you can put your thumbs together for me, like that. Perfect. There's a space in between his thumbs, no clubbing is present. And earlier when I was assessing his cranial nerves, I wanted to do his sensation as well, so we'll do that now. Listen, close your eyes and just tell me when you feel this.
Now. 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 Now.
Perfect. So I wanted to make sure we included that cranial nerve for sensation. And now that I'm back to the upper extremities, I'm going to assess for Ben's radial pulses, also his brachial. So we've got 3+ pulses on the radial and brachial areas, which is normal for both. Now that I've assessed that, I want to assess his strength, also range of motion of his upper extremities. If I can have you raise your arms up, now bring them down and abduct them outwards like this. Now put them back behind your shoulders. Perfect. Any pain with that?
No.
Okay. Now I want to test your strength. You can try to raise your arms up while I push down on them. Now the other way. Perfect. Now if you can kind of try to abduct them, and now adduct them. Beautiful. So now we tested the strength of the upper extremities, and the next area I want to move to is the lungs for Ben. So we'll start with that. Usually you want to start by inspecting your patient's ability to breathe, just their respirations. So watch Ben breathe as I have been painting my assessment. Make sure there's no use of accessory muscles, any trouble breathing. And the first thing I want to test, I'll inspect his back, his posterior chest, but I also want to test for expansion. And I'll put my thumbs close to the bases of his lungs while he breathes. And I'm looking for my thumbs to separate as he inhales and come back together as he exhales. Deep breath. Exhale. Deep breath. Exhale. Perfect. And now that I've tested for expansion, I want to test for tactile fremitus. So I'll be putting my hands on his anterior and posterior chest as he repeats 99. I'll do the apices, the middle lobes, the bases, also lateral walls on the anterior and posterior chest. Say 99.
99. 99. 99. 99.
Right. And while I'm assessing that on the anterior and posterior chest, I'm also palpating his costovertebral angle on the anterior and posterior. Any pain or discomfort?
No.
Do 99 again.
99. 99. 99. 99.
Beautiful. And what we're trying to feel for is for symmetrical vibrations with both hands while we're palpating. Now that we've palpated, I want to move on to percussion. And while I've got Ben setting up, I'm going to percuss the anterior and posterior chest. Basically looking for resonance over the lung fields. You get to more dullness as you go down, further down the back, or the anterior and posterior chest. That was the anterior chest. Now that I move to the posterior, I'll have Ben hunch over, kind of like he did earlier. While I assess the posterior, it just opens up the lung fields for me. While I'm percussing, another thing I want to test is diaphragmatic excursion. So basically, I'm going to have Ben first take a very deep breath. I'm going to percuss starting at the apex of the lung down to the base on the right side. I'm going to mark where that sound changes from resonance to dullness with a piece of tape. And then I'll have Ben take a few regular normal breaths and then have him exhale fully and hold that. And I'll percuss back up from dullness to resonance, mark that with a piece of tape. Normally that area is about 3 to 6 centimeters. After that, I'm going to do the same thing on the left side of his posterior chest and compare the two measurements. And usually the right side is higher than the left just because of the position of the lung over the bulk of the liver to the right. If you can take a deep breath for me and hold it. Alright, I'll take a couple regular breaths. Now take a deep breath and exhale fully and hold that. Alright, so we have that mark on the right, we're going to repeat on the left. If you can take another deep breath and hold it for me. Alright, now a couple regular breaths. And then a deep breath and exhale fully. Alright. And then next I'll get a ruler and measure the distance between the marks. Looks like we've got 4 centimeters on the right, 3 on the left. And the mark on the right is a little bit higher than the left, but that's normal finding. And last, with the percussion, I want to percuss the costovertebral angles again. As we palpated them earlier, I want to percuss the anterior and the posterior. You can kind of lean back for me. Any discomfort?
No.
And I'll have Ben kind of hunch forward like he did before. Any discomfort there?
No.
Fantastic. And now that we've done that, the last step I want to do is auscultate his lung fields, and I'll do so on both the anterior and posterior chest. And after this section, we'll move on to the heart. And have you take some deep breaths for me. Now we're going to auscultate the anterior. Also, when I get to the lateral walls, to Sometimes it helps if the patient raises their arms above the head just to get better access to the lateral lung fields. So deep breaths. Raise your arms up. All right. And Ben's lung fields are clear throughout, anterior and posterior. Now that we've done that, I'm going to have Ben lay down while we do the cardiac portion and the abdominal assessment. From there, we'll move on to the lower extremities and finally the remaining musculoskeletal exercises, and I will conclude the assessment. You don't mind laying down for me? The first thing I want to do with Ben laying down, I want to inspect his chest. I'm going to look for chest rise. Also look for any pulsations that might be visible, any chest heaves, any lifts. Also, I'm going to listen to his carotid arteries with the Bellamont stethoscope, listen for any bruise that might be present. When I palpated them earlier, I felt no thrills, but we'll listen for bruise. And since we did our percussion earlier with our lung assessment, we'll move straight to auscultation for heart sounds. Basically, I'll start on the right side of his chest with the aortic area, move over to the left second intercostal space for the pulmonic, third intercostal space for the Erb's point, fourth for the tricuspid, and then his fifth on his left space, which is usually the fifth midclavicular line. I'll be listening for his apical impulse. A lot of times if you're having difficulty hearing the apical impulse or the mitral area, you can have the patient roll over to their left side. For Ben, I can hear it clearly enough. I don't need him to do that right now. For the next part of the assessment, we're going to do the abdomen. I'm going to have Ben lift his shirt up just to expose the abdominal area. And if you could also bring his feet up, bring his knees up to his chest, that'll better help flatten out the abdomen area and expose that area as well. And the first thing I want to do, as with the other body systems, I want to inspect. The only difference with the abdominal region with that body system, we're going to auscultate first before we do any of our palpating or percussing. So inspecting his abdomen, I can see the umbilicus is midline. Also, there's no masses present, no hernias. Next thing I want to do is auscultate. I'm going to listen to the four areas of the four quadrants of the abdomen and listening for active bowel sounds. Ben's bowel sounds are active in all four quadrants, normoactive, they're not hyperactive or hypoactive. Next thing I want to do, I'm going to do the percussing, and then I'll move to light palpation, then deep palpation. When I'm percussing Ben's abdomen, you want to hear dullness over solid organs and typically tympany over the rest of the abdomen. I'll start by going down the right side, then the left side. Then I'm going to percuss his liver borders, which would be down the right side. I usually start at the right breast, move my way down. When the dullness moves to tympany, mark the bottom border of the liver, tympany back up to dullness, top of the liver. I'll percuss for the spleen also. Then we'll move from there, we'll do palpation. I'm going to palpate the liver, the spleen, also his kidneys, right and left. And then before I do those, I want to auscultate for any bruise that might be present. So I'm going to listen to his arteries. We're going to start at the abdominal aortic, and I'm listening to the kidneys, or to the renal arteries. Then I'm going to do the iliac, and then the femoral arteries. So no bruits were heard over those fields, which normally you wouldn't expect to hear any. So next we'll move on to the palpation, or to the percussion. Then I want to mark the borders of the liver, also the borders of the spleen. Normally the liver would measure about 6 centimeters. After percussing those, we'll move to light palpation. I'll make sure Ben doesn't feel any discomfort, and then we'll move to deep palpation, and mainly palpating the liver, the spleen, kidneys, and then lastly I want to palpate for any abdominal aortic pulsations that might be present. And if you feel any discomfort here. Any pain?
No.
All right, and that concludes our portion of the abdomen. Now that we're done with this body system, I'm going to move on to Ben's lower extremities. After the lower extremities, we'll do our remaining musculoskeletal. Ben, if you can sit back up for me. And earlier when we were doing the upper extremities, I meant to test Ben's brachial reflex, so I'll do that now. And I'll have Ben relax his arms on his legs, and then use my finger as the source that I'll tap with my reflex hammer. All right, so reflex is present in both arms bilaterally. Now we're going to move on down to the lower extremities, and just like earlier, I want to inspect first. I'm going to look for skin, hair distribution, make sure there's no masses present, no irregularities. Also feel for temperature, for warmth, and we're going to check for edema also on the anterior tibial and malleolus areas, so we're usually the best spots for that. I want to feel for his pulses too, just as I did earlier with the radial and brachial. We're going to feel the post-tib, pedal, and also the popliteal pulses. Kind of relax your legs there. So no edema is present. We've got 2+ pulses, pedal, post-tib, and popliteal. Next, I want to check his reflexes. We'll do some deep tendon reflexes. We'll do the popliteal, also the Achilles. Reflexes are present in all 4 areas. With the foot, you're looking for plantar flexion as you're tapping it with the reflex hammer, and for the patella reflex, looking for the legs to extend outwards. And now that we've done those, I'm going to have Ben stand up. You don't mind standing up for me? We're going to check out his lumbar spine. We checked out the cervical earlier. Now I just want him to try and bend over, touch your toes. And I'm looking at the spine, looking at the curvature. You can come back up now for me. I'll have him lean side to side. Right. And if you can go backwards too. as far as possible. Perfect. I just want to make sure there's no pain, discomfort in those areas. And now if I can have you, I'll have Ben walk a straight line. Then I'll also have him walk toe to toe or heel to toe. And that should conclude our assessment.
Yeah.
Walk this way. And back towards me. And we'll have him walk heel to toe. And then the last one we'll include is the Romberg test. Basically, I want to test his balance even more. So I'm going to have him close his eyes with his feet together, touching each other, and just see if there's any swaying or any movement. Close your eyes for me. And we'll do this for about 20 seconds. That's good. Yeah, good job. So that concludes my head to toe physical assessment for Maryville University. Thank you for watching. Thank you, Ben.
Thank you.